Hi, my name is Ariana Vera. I am going to talk about liver involvement in autosomal dominant polycystic kidney disease. Definitions. Hepatic involvement in the most common extra-renal manifestations in autosomal dominant polycystic kidney disease (ADPKD). Cysts are responsible for most liver complications, but other life changes can occasionally be found: shots and congenital liver fibrosis and segmental dilatation of the biliary tract.
ADPKD stands for Autosomal Dominant Polycystic Kidney Disease. ADPKD is the most common type of polycystic kidney disease, or PKD. PKD describes a group of hereditary diseases that cause cysts to grow and form in the kidneys. Over time, they expand, making the kidneys grow larger. This makes it hard for the kidneys to function normally and can lead to kidney failure. About 1 in 2,000 people in the United States have been diagnosed with ADPKD. ADPKD is found equally in men and women and among all ethnic groups. ADPKD is hereditary, meaning that it runs in families, and is the result of mutations or changes in specific genes called PKD1 and PKD2. Autosomal dominant refers to how the disease is passed down from parent to child. If one parent has the disease, their children have a 50% chance of inheriting it. 1 in 20 people with ADPKD develop the disease with no clear family history. Most people with ADPKD don't notice any symptoms until they are between 30 and 50 years old. But even if a person with ADPKD doesn't feel like anything is wrong, the disease may still be progressing. Let's take a closer look at the disease itself and find out what ADPKD does to your body. ADPKD can cause problems for many parts of the body, including the liver, the pancreas, the spleen, the large intestine, the brain, and the walls of the abdomen, as well as the heart and blood vessels. What are the signs and symptoms of ADPKD? When signs and symptoms do begin to appear, people with ADPKD may notice things such as back or side pain, an enlarged abdomen, or blood in their urine. They may also develop high blood pressure and experience frequent urinary tract infections. Thinking ahead about disease progression can lead to feelings of anxiety and worry. ADPKD may even impact some people's decisions about whether or not to start a family. ADPKD is the fourth leading cause of end-stage renal disease, or ESRD, including kidney failure. In ESRD, the kidneys stop working and can't continue to filter the blood and clean it properly. The filtration rate, sometimes called GFR or eGFR, goes down, and the amount of waste products in the blood, like creatinine, goes up. Approximately 1 in 2 people with ADPKD develop kidney failure by the age of 60 and will need dialysis or a kidney transplant. Dialysis can lead to poor quality of life, and kidney transplants can result in complications. If you have a history of ADPKD in your family, it's important that you get screened. Understanding the symptoms that can come with ADPKD is important. If you think you may be experiencing symptoms of ADPKD but have not been screened, diagnosis may help manage future complications. You may even want to talk to a special kidney doctor, known as a nephrologist. Although there is no cure, it's important to understand the signs and symptoms of ADPKD.
Applications in medicine. The molecular and cellular changes involvement in liver cystogenetics have frequently been illustrated by advances in the genetics of genetically modified animal models. Although most patients with ADPKD do not report liver symptoms. Some experience chronic manifestations related to a progressive enlargement of the polycystic liver. Pros and cons. Pros: An arsenal of surgical procedures can be conferred to the most disability patients, including liver resections and transplantations. Cons: The disability may severely affect their quality of life. A few developed acute complications that followed a life-threatening course. Early complications and mortality after either procedure remain frequent.
Autosomal dominant polycystic kidney disease, ADPKD, is a rare genetic disease characterized primarily by the development and progressive enlargement of fluid-filled cysts within the kidneys. ADPKD is a systemic disease characterized by both renal and extrarenal manifestations. Over the course of disease progression, common sequelae include cyst infections, cyst hemorrhage and hematuria, intracranial aneurysms, hepatic cysts, hypertension, back pain, side pain, and urinary tract infections. ADPKD is an inherited condition. When one parent has ADPKD, their children have a 50-50 chance of inheriting it. However, even patients within the same family can present with variations in disease characteristics, such as age of onset and rate of progression. ADPKD can initially be difficult to detect because symptoms may be scarce in early-stage disease. Over time, the enlarging cysts can cause an increase in total kidney volume up to 4 times its normal size. The development and progression of these fluid-filled cysts can contribute to compression and loss of the surrounding functional renal tissue over many decades. However, in early-stage disease, healthy nephrons compensate for damaged nephrons, causing estimated glomerular filtration rate, eGFR, to be normal or slightly reduced despite the fact that damage is occurring. eGFR can remain intact through prolonged periods of time due to compensatory hyperfiltration, but will ultimately decline steadily thereafter. So while the enlarged cysts can ultimately contribute to irreversible loss of kidney function, the progression of ADPKD can be difficult to track because kidney function alone is not an effective indicator of disease advancement. ADPKD can progress significantly while eGFR presents as normal. In these cases, a normal eGFR may be masking irreversible kidney damage. In most patients with ADPKD, serum creatinine levels do not rise until a patient is in his or her 40s or 50s, when the kidneys are grossly enlarged and previously healthy parenchyma has incurred serious, irreversible damage. Therefore, it may be better to measure both eGFR and total kidney volume, TKV, when assessing disease progression. The two main mechanisms leading to cyst formation and expansion in ADPKD are fluid secretion and cell proliferation. A key driver of these mechanisms is an increase in intracellular levels of cyclic AMP. Cyclic AMP is a secondary messenger molecule that controls various cell signaling pathways. Cyclic AMP leads to the activation of CFTR chloride channels, resulting in fluid secretion. Cyclic AMP-mediated activation of cell proliferation has been shown to occur via activation of pro-proliferative pathways, such as MAP kinase. Elevated cyclic AMP levels in ADPKD are believed to be driven by two main mechanisms: impaired calcium regulation of renal tubular epithelial cells driven by genetic mutations of PKD1 and PKD2 genes, and elevated serum levels of vasopressin, an antidiuretic hormone, also known as AVP or ADH, and upregulation of the V2 receptor. The genes PKD1 and PKD2 encode proteins present in renal tubular epithelial cells. A mutation in PKD1 is responsible for a defect in polycystin 1, PC1, a transmembrane protein located on the primary cilia and cell membranes of renal tubular epithelial cells. Patients with a PKD1 mutation account for approximately 85% of all ADPKD cases and are characterized by rapid disease progression. A mutation in PKD2 is responsible for a defect in polycystin 2, PC2, a non-selective cation channel located on the primary cilia, cell membranes, and endoplasmic reticula of the renal tubular epithelial cells. Patients with a PKD2 mutation account for approximately 15% of all ADPKD cases, in which the disease progresses more slowly. These defects in either PC1 or PC2 can disrupt calcium homeostasis in the renal tubular epithelial cells, resulting in decreased intracellular calcium and a subsequent increase of cyclic AMP. This can lead to impaired regulation of the proliferative and secretory pathways. Vasopressin is a powerful modulator of cystogenesis via binding on vasopressin V2 receptors and stimulation of cyclic AMP production. Vasopressin levels have been shown to be elevated in ADPKD. Studies have shown that vasopressin is actually the main driver of elevated cyclic AMP levels in renal tubular epithelial cells. Studies have also shown that both vasopressin and mutations in the PKD1 or PKD2 genes are required to lead to the development of cysts in ADPKD. Therefore, impaired calcium regulation and elevated levels of vasopressin contribute to an increase in the production of cyclic AMP. In summary, increased cyclic AMP levels resulting from low intracellular calcium and elevated vasopressin lead to an increase in cell proliferation and fluid secretion, the main mechanisms of cyst formation and growth in ADPKD. Over time, these cysts contribute to an increase in total kidney volume, destruction of kidney tissue, and diminishing kidney function. And while much is known about the etiology and pathophysiology of ADPKD, advancement of the disease can often go unnoticed, as normal kidney function can mask the severity of disease progression until irreversible damage has already occurred.
Issued a plea in Ecuador. Polycystic kidneys are the cause of 10% of patients with stage chronic kidney disease. In Ecuador, renal replacement therapy reached a total of 8,253 patients with this treatment in 2013. Conclusions. In the future, claim identifications of genetics and environmental modifiers will increase understanding of liver disease, development and growth, and health identify patients who are at risk for developing an extreme liver phenotype. In the meantime, for patients with the massive liver disease, it is imperative to develop rational guidelines to establish in the indications for liver resections and liver transplantations, respectively, and well as their optimal timing. Thank you.